Martin, I think it's 9 o'clock. We can get started.
All right, we will get started. My job this morning is very easy. That is just to welcome you all to this meeting. This has been a very, very interesting year for all of us. When I accepted the second year as the chairman of the board of Healthy Start, I didn't quite realize what I was getting into, and no one else did either. But I've been on the front lines mainly as an observer as how Healthy Start has responded to this pandemic. And for those of you who work for Healthy Start, you know this. Those of you who volunteer and have interest in Healthy Start, you probably know this as well. But this organization is something that I am very proud of being a part of, and in particular this year, as they have performed their services above and beyond and stepped up to the plate and did their job. They did that because they're good people and they have great leadership with the staff and administration and what they do. So I've been honored to be the chairman of the board. I have done nothing more than give lip service to leadership, so get their job done. And this organization did what they needed to do and more to get through what we have had to deal with maturity and respect that I would expect out of a much more mature organization. Just perfect. So with that, I'm very proud to be here, to be at this meeting today, and to introduce your leader, who you know well, and turn the meeting over to Jane Murphy, Administrative Head of Healthy Start Hillsborough County. So Jane, it's all yours.
Thank you, Dr. Yelverton. I agree. We've had as everybody has had an incredible year. I'm going to do just more of the highlight reel on that in just a minute. But I think that our partnerships and our funders and those that provide Healthy Start and all the other services that are part of our system of care have been spectacular in the level of support and the can-do attitude. And we need to move our whole system of care remote in a week, and just how to get no whining, just let's get it done. And y'all have all been a part of this, and I really truly appreciate it. So I'm going to give first, if you have any questions about any of the presentations that we have today, I would appreciate it if you put it in the chat. We probably won't have time to answer, but we can address your questions later. If you would just say hello in the chat, that'll help us to take roll and let everybody know who's been in attendance. So I appreciate that. And also keep your microphones off if you don't mind, so we don't have backlash. So that's our housekeeping. So I'm going to start with our year in review of our programs. As y'all know, Healthy Start, there are 31 Healthy Start coalitions in the state of Florida. We are approaching our 30-year birthday, and as someone that was there at the beginning, we have come a long way, literally, baby. Hillsborough is unique in probably having the most, you can go back to the previous slide, the most number of programs. We've got Healthy Start, Healthy Families, Nurse Family Partnership, Safe Baby, the Women Resource Specialists at WIC, and our Adolescent and Teen Health Initiative. Also new on the block is our Plan of Safe Care and Healthy Steps. Next. Many of you heard me say this many times, and I never get tired of it, and y'all may get tired of me saying it, but we have over 17,000 births, and that is more than 11 other states. And we are rural, we are urban, we have all kinds of the complexities of both those environments. And so there are challenges to that. And out of all of those births, we screened over 11,000 women, and we screened like 99% of the babies, because in Hillsborough, we have a complex system where we actually have folks in the hospital that either work for us or work for the hospital, but are funded by Healthy Start, that they're able to do a face-to-face triage or virtual triage now, to let everybody know and see what the mom and her family want, and then really help navigate her into those services. Next. Over 8,000 women receive services and almost 12,000 babies receive services. So you can look at that's a large number of the deliveries that we've had. Of that, almost 7,000 had prenatal, and then almost 11,000 infants. That's a lot of moms, a lot of babies, a lot of families. We've screened 85% of the pregnant and postpartum women for depression, and we have a unique system, unique to Hillsborough County, that we're doing the services, mental health services for pregnant and postpartum women. And we've been doing a lot virtually since March, but that has been a lifesaver, literally a lifesaver for many of the women we serve, and also for the system when we identify women that have postpartum depression or have other issues that need to be supported, that we're able to move forward with that. And you can see the other numbers of 60% of the ones that were referred were connected with a home visitation program. So that is really the triage and the linkage for our system of care. Next. Healthy Families is one of our premier programs. We serve almost 2,000 children. The key component to that, and we screen again and triage through the Healthy Start system, is that 99% of the participants remain abuse and neglect free. And that is, we're one of the evidence-based programs, and that makes a huge difference. They are screened into the program. They have to meet certain criteria to be a participant. And it's a 5-year program. It's very intensive, but also you see that 99%, over 99%, we're satisfied with the services. Next. Nurse-Family Partnership is another evidence-based program that we triage for, and it's been for first-time moms. We have 2 teams, which were added through a complex funding, and we're delighted to be able to have capacity in those programs. They're part also of one of the teams as part of our plan of safe care, and they have served 339 families, but that's over 4,000 home visits. As it says, nurse family, it is a nurse. We've got 40 years of evidence to show the long-term effects of having this partnership and having this nurse-family partnership with the family. And it goes even to when the children are teenagers, their reading levels, their juvenile detention rates, all of those are much improved from this early onset of nurse-family partnership. Next. We have a Safe Baby program. Our key element of what we want to do is to keep babies safe, and the leading cause of infant death is sleep related, but also the safe caregiver, which is also goes in with that. So they've educated just last year 750 professionals, but that team has educated, I think, over 14,000 professionals in the last few years on what is safe baby, so that we can get the word out about what is safe sleep, which is really important, that babies are sleeping alone, they're sleeping in a crib, and that they're also looking at their safe caregiver. They also help with what's coping for crying. They also do developmental screens. That's funded by the Children's Board. We also have women and infant resource specialists that are in 7 WIC locations. And that is an enormous support to the families. And I can tell you this last year, they have been able to break the code of how to provide the services to women, and have really been a safety net for a huge number of women that may have not wanted other services, but then they come into WIC and in their life they've had issues, or that when they were originally screened. So it gives us another safety net for families. Next. Our adolescent teen health. This is a new program with us, and we've worked really closely with the youth clinic at USF. They've done an amazing job. Their social media they've got a youth advisory committee that puts most of us to shame of what kind of social media they've done. They've started a Teen Connect website that allows teens to be able to connect to find out where they can get valuable health resources. And they've done a lot of connecting and resource inventory, resource mining, and letting the kids know what's out there. And we're very proud of what they've been doing, and it's just beginning. Next. Plan of Safe Care, we originally funded by Hillsborough County, and then we received funding by the state and CAPTA, and then locally Eckerd. There are 3 components to it: the pregnancy medical home, the hospital-based services, and substance-exposed newborn clinic. It really working toward women that are families that are at risk of having their children removed, to try to prevent that by wrapping around services before the baby is born, and then providing the needed support. Dr. Wright is going to go into a lot more detail at the end of our program today, but this has been a huge success. And I think we're really, again, it's another safety net for families that may have not wanted services, but it allows them to continue to have their children seen, and we can provide services for their children. Next. We have a PD clinic, part of the Plan of Safe Care at Mary Lee's house, Dr. Wright, and then we have 2 nurses that work with it. And they have already, in less than a year, seen 148 newborns, and then they've received 377 referrals through the whole Plan of Safe Care. We have staffings once a month where we really look at everybody coming together to help try to work towards success for that family. And that success is framed differently for every family. This is all of our funding. It gives me a little bit of a headache because each one of those has a different, some of them, I think we have 3 or 4 different dates, fiscal years for each one. And but this is where our funding partners have funded us, and we have done a lot of braiding of funding, and that allows us to really strengthen the programs we have. And we're very grateful for that funding. We want to thank our funders. These are all the funders that are listed here. The Board of County Commissioners, the Children's Board has been a funding partner for many years and funds many of our programs, and we're very grateful to them. The Department of Health, they have been our initial funder from day one, and our new funders at Eckerd Connects and the Florida Association of Healthy Start coalitions. And so the Ounce of Prevention and is funding Healthy Families, and Healthy Families is also funded by the Children's Board. And our partners, this is really where I want our heartfelt thanks to all of our partners that we've listed here: the hospitals, Reach Up, Success for Kids, USF Pediatrics, our WIC Health Department partners. A lot of the heavy lifting comes from all of these sites. Of the partnership, I believe, is a true partnership where they really, and we've seen such evidence this last year of really working so hard together to problem solve, to make things work, and to allow us to go into a virtual world that we had not prepared for. And within literally 10 days, I think we were all ready to roll and we were out there. So thanks to all our partnerships, and we're well aware that our staff, we stand on the shoulders of our partners as they are really helping us to provide the services in the community. Okay. And I wanted to next, we have a new initiative, Healthy Steps, that we're not in the clinics yet. It's an evidence-based program that will be in the USF clinics, which they'll do the training in January, and will be in the clinics very soon. We also have a task force, the Black Infant Maternal Maternal Mortality Initiative. And I want to introduce Cheri Wright-Jones. She is the project lead. She is currently the senior program officer at CARES in Pinellas. They're distributing $30 million of CARES funding. She served for many years as regional vice president of Allegheny. And she's one of the beginnings of her career. She's worked with infant mortality and racial disparity for many, many years, was the Closing the Gap. And she has been a great partner and is really helping us bring this to life. So I want to introduce Cheri Wright-Jones.
Thank you so much, Jane. Good morning, everyone. I have the wonderful opportunity to share a little bit more about the work that we'll be undertaking and formatting a plan to address Black infant maternal mortality in our community. I hope that my presentation today will give you a glimpse into the work that the task force, along with the community, will be doing over at least the next year. I want to begin by thanking Jane and her team for their leadership. The coalition has been involved in this work for many years. Of course, our partnership would not be complete without the help and the partnership of Reach Up Incorporated. So special thank you to Lo Berry, the president and CEO of Reach Up, Dr. Austin, and the leadership team, because they've been working around racial disparities, particularly when it comes to infant mortality, for well over 20 years. So I just want to say thank you to them. So why are we here and how did we get here? Black infants in Hillsborough County are still 3 times more likely to die than white infants. And the 20 years that I've actually been working around this initiative when I first started, that statistic, unfortunately, has not changed. Black infants in Hillsborough County are still 1.5 times more likely to be born prematurely than white infants. Black infants in Hillsborough County are almost 2 times more likely to be born low birth weight and almost 2.5 times more likely to be born with very low birth weight. Unfortunately, we have significant disparities with our Black mothers as well. Black mothers in Hillsborough County are 2 to 3 times more likely to die from pregnancy-related causes than white mothers. And we think that these are areas that we as a community and as a coalition can address. Next slide, please. So health equity. We can't begin to talk about changing health outcomes without addressing health disparity. This continues to come to the forefront. If you go back 1 slide, please. This continues to go, and probably for many of you, you're well aware of this work through naturally what you do every day. I'm sure many of you see the disparities that exist within many of our communities of color. And so with that, we're always looking for how do we improve the health of our communities. And one of the things that we have to do is pay special attention to those that are experiencing the greatest risk. We usually compare those who have decent outcomes with those who have, I would say, poor outcomes. But we know that if we improve the health disparity for those who have the worst outcomes, we will also be making improvements for those who have, who oftentimes fare better. Next slide, please. So it's difficult for us to enter into this work without having a lens around racial disparities, particularly when it comes to health equity and to trying to address health disparities. And so here's a definition as defined by Healthy People 2020. And so as we think about our work, as I've just shared with you a little bit more about Black infant and maternal mortality, particularly in Hillsborough County, you can see that there is a racial disparity gap. And so through our work with the task force, we hope to address that. Next slide, please. So now we're at the action phase and getting to work to address the challenges that mothers, particularly Black mothers and infants in our communities, are facing. We want to engage others, as this will be a broad-based community approach to learn and understand what's happening in real time, and hopefully trying to be able to be responsive to that. Next slide, please. So on to our task force and the purpose of the Black Infant and Maternal Mortality Committee. Over the next year and a half, we will develop an intentional and systemic community action plan to address this issue. This work will be done in collaboration with our community partners along with the community. One of our goals is always to share the lived experience of those that are involved in the data and those who are experiencing this specific challenge. Our work will not be complete if we do not ensure that we include community, particularly Black moms, dads, and their families. They are key and important in this work. Next slide, please. So our anticipated goals. We have already successfully completed the first one. We've established a task force based upon community experience and data, and they are actively working to achieve and to begin to build the community action plan in tandem with community members. We will develop an intentional systemic community action plan to address this issue that's going to be focusing on Black infant and maternal mortality. We will, of course, be highlighting the existing work and create positive changes throughout our collaboration. And we will work with consumers of services and other community partners to raise awareness and pursue solutions. These goals might be changed and tweaked as and based upon community and the task force input. Next slide, please. So phase one has successfully been completed. And so I want to give you an overview of what we've been up to since August. As a planning team, we have been working behind the scenes to develop the project idea, review the data, confirm and finalize our task force members. We began to brainstorm the initiative. And finally, we are in the throes of working to refine our plan and what that will look like. So that's a little bit about phase one. Phase two will ensure a stronger commitment and input directly from community members along with the task force. They will help us develop phase two of the initiative. Next slide, please. So our call to action, and this is where all of you all will come into play. I want to say before I move into the call of action that there will be many opportunities for engagement. So if you have an interest around helping us achieve better health outcomes for Black infants and mothers, please do not hesitate to reach out to me. We will be having subcommittees, subgroups, and things of that nature. So there are plenty of opportunities to engage. But this is where we need you today as a champion. We invite you to join our campaign to reduce Black infant and maternal mortality in Hillsborough County. We need for you to help us advocate for the initiative through legislation and operational policies that support pregnant women and their families. We need for you to help us educate your colleagues, your family, your friends, your neighbors about the challenges of Black infants and their mothers and what they have in terms of their lived experience. We need for you to help us find Black families who are willing to share their experience. And lastly, and not most importantly, as we need your commitment to supporting all mothers and families, not just Black mothers and their families. Next slide, please. So thank you. There is my contact information. I do just want to give a special shout out and thank you to you for agreeing to be a champion in advance of this work and what we'll do. Of course, to our Black infant maternal mortality task force, to Jane, Lowe, Deborah, Sarah, and the entire planning committee. And Dr. Wilson, Dr. Austin, and Dr. Stanley, thank you so much for providing data and being such a rich source of information.
Thank you, Cheri. That was great. Cheri has been an amazing partner and has really led us through what we're very excited about in the future. I think we really have the opportunity to make some differences. So thank you so much, Cheri. Appreciate that. Next, I'd like to introduce Dr. Leisa Stanley. We are in the process of doing the needs assessment, and Leisa has been working diligently and has been compiling very rich data that helps us look at what the problem is to help us bring us toward what the solutions are. So I'd like to introduce our Associate Executive Director, Dr. Leisa Stanley. Leisa, are you on? You all do not want me to give this.
I'm so sorry I had myself on mute. Forgive me. Let me start again. Good morning, everyone. Thank you, Jane. I'm so glad to be here to talk about the work of the past year and a half on our next needs assessment due to the Florida Department of Health at the end of this month. This is the work of the Plan Development Committee, the Fetal Infant Mortality Review Committee, and our Board of Directors, and many of you have been involved in this process. And today, I'm just giving you a brief summary. If anyone would like additional information, you are free to contact me. Next slide. So let me talk about the analytics that we've been through over the past year and a half. We have looked at trends within our vital statistics data for those key MCH indicators. We've looked at 10-year trends. The latest final data we had available was 2019. So we have looked at what's occurring with neonatal and post-neonatal infant mortality, our fetal deaths, which are those deaths that are at least 20 weeks gestation that don't end in a live birth, our low birth weight, our preterm births, and the disparity between Black and white infants and Hispanic and non-Hispanic white infants. In addition, the perinatal periods of risk analysis gave a great framework because we can look at age and birth weight at death for both fetal and infant deaths. And then the partitioning of our infant mortality really allowed us to determine, was the infant mortality due to birth weight distribution, just meaning we had in certain groups a higher rate of very low birth weight infants being born, or was it due to mortality because they were dying at a higher rate within that birth weight group? And we found that it really had to do with that birth weight distribution. I'll talk about that in a minute. I did logistic regression models for the last 3 years of data that we had a birth cohort to do them on to really look at significant risk factors. We looked at our femur data to look at our deaths that were due to sudden unexpected infant death, those sleep-related deaths. We were able to get data from the 2019 community health assessment done by our area hospitals as well as our health department. And this was a rich data source of where I was able to get the data for women of childbearing age. They looked a lot at those social determinants of health around housing, neighborhood safety, food insecurity, access to mental health care, access to healthcare services. And then I was able to do some community meetings this year to get some conclusions from some of our community partners. Again, this was a unique year for us because of COVID, so everything ended up this year being virtual as we continued into our needs assessment process. Next slide. So we have two areas of focus for the needs assessment this year. This slide represents a year and a half of data and the data from the previous slide that I don't have time to go into today. But basically our focus areas are going to be those infants born too soon and too small. They represent 75% of all of our infant deaths. 65% of these occur in that first 27 days of life. I would share with you that this is really about our neonatal mortality rate. It has been declining. In 2018, we had the lowest rate we've ever had in Hillsborough County. And then we saw some increases in 2019, really due to those very small, less than 500 gram infants. Our disparity is about 2.2, and I know many of you may remember lines in that disparity over the years, over the last few years. And so we're grateful that our disparities declined, but it's still significant. And that's why we need that task force. Hispanic to white non-Hispanic disparities also around a factor of 2. That is also significant. So those two disparities we really want to focus on. And then sleep-related conditions are that second area where 38% of all of our deaths are in this area. 85% of these occur after the neonatal period, after baby's gone home. 28% though are preterm and low birth weight. I would let you know that when we look at SUIDs, our sudden unexpected infant death rate, we do have a disparity between Black and white of about 3.5. So we're continuing to work on that. We have seen some increases in this rate this year that we think is due to COVID. What we're seeing about family having more than one family in a housing unit, what we're seeing with sleep-related environments. Next slide. Next slide. Can we advance the slides? There we go, great. So we're moving this year to looking at driver diagrams versus health problem analysis. Can we go back a slide? There we go, thank you. And I just wanted to share with you briefly that this isn't too much different than what we've done in the past. It's just a different way to frame what we're doing into a continuous quality improvement environment. So our needs assessment looked at aims and goal statements around reduction in neonatal mortality and those SUIDS deaths. It's what we want to improve. It's using those SMART goals, and it's the goal of our quality improvement. And I think many of you are familiar with that. Our primary drivers came from the needs assessment. I'll talk about those in the next slide. That's our theory of change and factors that we want to address to improve our infant mortality. And our secondary drivers then are those things that influence the primary drivers. And that's where we're really going to focus on creating our interventions. And those interventions that we're now calling change ideas or bundles will be the work of the Plan Development Committee beginning in January. Next slide. So our focus areas for this service delivery planning cycle will be maternal mental health and chronic conditions, maternal weight management, prenatal care access and utilization, interpregnancy interval, and the issue of co-sleeping, sleep environment, and sleep position. And I'm going to talk about these work groups in the next series of slides. So next slide, please. So as we're addressing prematurity and very low birth weight, we are going to create work groups in the following areas: social support and fatherhood engagement. This is around that area of both maternal and fatherhood support. And this really relates back to mental health and what we're trying to address for these women. As I'm going through these work groups, if you think you would like to participate in a work group, you can put your name in a chat box with the work group you'd like to participate in, and I'll be in touch with you. We'll be creating those work groups. They'll begin meeting in January on that third Tuesday of the month at 9 a.m. Access to mental health services. We want to look at the navigation of that system, payment for services and insurance, language barriers, telehealth services, which really has come out of COVID. We have families where telehealth services are problematic and difficult for them. So we want to figure out what we can do about that. And then we have to figure out, as we look at mental health, do we have a sufficient number of providers? The continuity of healthcare across the lifespan relates to not only prenatal care access, but primary care access. This is that life course perspective for women, making sure that we're not just addressing their health when they're pregnant. Again, we're looking at practices and provider offices that may hinder women from seeking care in terms of their treatment. The system navigation, especially between pregnancies and into primary care, insurance status, system navigation, again, the telehealth issue, and perception of provider treatment, which really came up in the community meetings for women, especially women of color, feeling that they're not respected, that there's a, that treatment hinders them from attending that visit. And so I'm sure we'll be working with Cheri and her group on some of those issues that really cut across those domains. Next slide, please. Interpregnancy interval, we'll be working with the Adolescent Health Advisory Board as well as within our other groups about this piece. We know it's critical, but we know access can be a problem here, so we want to work on that. Patient education came up when you're talking about a chronic health condition, and what kind of education is a woman receiving from her provider? Is it in her language? Is it understandable? Does it recognize her culture? So we want to talk about are the things we can do in our programs to help educate our patients before they go to their provider about chronic health conditions or their pregnancy. Healthy weight management, obviously it's for us, we want to focus on WIC access and how we can work with our families based on the food they have available to them. I think food deserts get into those social determinants of health that we'll address later in our planning process. Next slide, please. And then for SUIDS, we're going to let our FEMR committee and our coalition staff continue to work on this issue. We're really looking again at expanding those outreach opportunities, those educational materials, and the community marketing around safe sleep and sleep environment. What we're seeing in FEMR is an increasing use of pillows, boppy pillows, babysitter pillows, regular pillows. The infant's placed to sleep on a pillow, sometimes in a crib, sometimes in an adult bed. Sometimes just their head is put on the pillow, but they're suffocating. And we're looking at maybe we could do a community marketing campaign, partnering with our community partners to let families know that's not safe, even if they're in a crib by themselves, to be on a pillow. And then we're seeing some issues again around those social determinants of health, around neighborhoods and housing, of where families are living, the housing they have available to them, and the fact that they're not safe for infants and maybe contributing to this rise we're seeing in these deaths. Next slide, please. So social determinants of health that came up again and again, and this won't surprise anyone on this call: transportation, childcare, neighborhood safety. This really came up in the community meetings about the sense of isolation of many of our mothers during COVID. And they're in unsafe neighborhoods. They don't leave their homes. They're very isolated. And so that's was a continuing issue, along with affordable and safe housing, this issue of food deserts, and then this economic self-sufficiency. What continued to come up with this sense of hopelessness for these mothers, that the thought of job training, education, employment isn't even on their radar. These are big ticket items. As Jane and I have said, if we had a few $1 billion, we might be able to solve them. But what we need to do is figure out how to develop those community partnerships and move forward. So I feel like we'll begin to work on this maybe that first year in developing those partnerships, and then really try to dive into that in years 2 to 5 or 2 through 3 of the plan. We're not sure if the Department of Health is going to shorten the plan to a 3-year plan. Next slide, please. Our timeline, we've had our needs assessment approved by our board. It's due the end of this month. I'm furiously writing right now and trying to put in all this good work the community's done. We will begin to work again in January with our PDC work groups. We're developing a process that you all will go through to develop these change bundles. We'll allow the community, we'll try to do some review and response with the community. Maybe we can dovetail some of our work with the work of the Black Maternal and Infant Task Force to make sure that we're developing those correct interventions. Near the end of the spring, PDC will review this, and it's due to the Department of Health by September 30th. So that's our timeline, and that's where we're at. And I'm excited about what we'll be working on over the spring and early summer with the further development of this plan. And I will turn it back over to Jane.
Thank you so much, Lisa. There's an incredible amount of work that's been done to get to this point, but we're excited about how it will all come together. So thank you so much. And thank you for the Plan Development Committee folks that have been diligently hanging in there with us as we work towards this plan. Next, I want to introduce Dr. Tanner Wright. He's Assistant Professor of Pediatrics at USF Morsani College of Medicine. He works primarily in the neonatal intensive care unit at Tampa General, and he focuses on infants with in utero exposures to medication, drugs, and other substances. He's a medical director of our PD clinic, which is promoting early developmental intervention that's at Mary Lee's house. But I will tell you that he's going to be, oh no, what's she going to say now? I have learned a lot from Dr. Wright. The amount of compassion and partnership and integrity that he brings to working with the families that are sometimes could be called difficult, and looking at them through a lens of understanding is remarkable. And he has been our champion, and I know for a fact that we would not be where we are and have had the success without his compassion and leadership and really great partnership. So Dr. Tanner Wright.
Thank you so much for that. Those of you that know Jane, you know she's delusional, so that's perfectly well said. You know what to listen to and what to believe. All right, so let me see if I can share here. All right. Ooh. Perfect. So I kind of want to take a little bit of a step, and those of you who have heard me talk before know that I'm a big fan of what I call kind of potpourri talks, touching on a few different things to be able to give something that could be appealing to each person in the audience. the idea that I love to kind of look at observations on life, look at things through different lenses, and try to see if I can get every single person to take something away that maybe they didn't realize before, didn't know, or just a different view on where we're at. So I'll kind of just jump in just for kind of time's sake. So introductory exercise. What I'm actually going to do is there's actually a Zoom technology that what it's going to do is actually going to select someone at random. If your camera's off, it'll turn it on. And what we'll do is we'll have a conversation really quickly. By logging on, that's kind of consent that we needed for the video chat participation. So like I said, I'll just randomly pick someone, I'll bring you up, and we'll just kind of talk about some things. And I just want to kind of take this time to discuss something about your experiences. So talk about something, a personal example of some experience of parenting that may not have been right, something that maybe you're not proud of, something that you forgot. Maybe someone from an outsider would be like, I don't know if that's really great parenting skills. So like I said, don't worry, if you're on the phone, it'll select your camera, it'll turn it on, and we'll just start it off. So what we'll do is we'll kind of jump into that right now. That's complete a joke. There's no such Zoom technology. But what I wanted to do is I wanted to take this as a first exercise to kind of talk about, if we're able to connect even tiny experiences of emotion and how we can connect that to other people in the community. So, as I was going through that, you kind of want to take an inventory of what were the feelings that you were thinking. Those of you that may not have your cameras on, probably worried about your appearance, right? Is my hair like I clearly didn't have time to get my hair taken care of this morning, so that's a struggle every day. Worried about your knowledge or intelligence, right? Like I just jumped into this and we're going to talk about something, and you were worried about if I was, what kind of questions I was going to ask of you, if you were going to kind of jumble your words or mismatch your words, and maybe someone will lose respect for me if I say something wrong. The anxiety of just regarding judgment about anything you see on camera. Anytime we step into a Zoom meeting, I know every person does like the 34 angles to see what part of the office do I want them to see me. Or, those of you that are, sitting in bed are probably like, oh crap, if he's going to turn on my camera, what's going to happen? The stress about not being prepared, right? I literally jumped into it. I kind of gave you a little bit of pressured speech and a little bit of fast talking to kind of get you to the point where you weren't going to be prepared. And maybe even some anger about not having received guidance of what to expect, right? Got introduction and there's no title to what my talk is about. So you have no idea what we're going to get into. And then all of a sudden you're going to have to start participating. Could have brought about some anger. And so the idea of these common themes of the idea that if I can experience just even a touch of that emotion or that feeling of anxiety, stress, anger, maybe that can allow us to have a different lens on how we see people in the community. I kind of talk about, in the PD clinic, we specialize in families that have been touched by substance abuse, opioid use disorder, domestic violence, significant caregiver mental illness concerns, stuff like that. And they constantly have these types of feelings, but on a tremendously magnified scale. Whenever I talk to moms, and once I get to know them and build a relationship, and they're open and transparent with me about their feelings and their emotions, a lot of times they talk about shared experiences at either prenatal care visits or even pediatric visits, well child checks or sick visits. The idea of that they question themselves, like, am I going to be judged for being on a medication, right? So say I'm on medication treatment for opioid use disorder. A lot of the moms even have the struggle, their own personal struggle about being on a medication. And is that right? I know I'm told it's the right thing to do during pregnancy, but does everybody know that? Am I going to be judged because I'm on that? What do people think about that? What about the idea of them thinking that I'm irresponsible? There's plenty of moms that, may have had a history of substance use in the past prior to knowing they got pregnant. All of a sudden they get pregnant, and that is kind of the life change that they needed to kind of get a hold of their life and make big changes. But knowing that some healthcare providers may have that electronic medical record that shows a history of substance use in the past. So even though they may feel like they want to be beyond that, it's always going to tag along. And so do they judge me because I'm irresponsible for what I did in the past? Or any mother that we see, if a first-time mom and you really don't understand what's going on, you can read a million books about pregnancy and about parenting, and I can guarantee you that parents in the audience can tell you that there's not a single book that truly prepares you for all of pregnancy or all of parenting. So the fact of any time that you're a first-time mom, no idea what's going on, and worried about, if I ask a question, will they start to question my knowledge or readiness to be a parent? And that can be kind of an overwhelming feeling of anxiety in some of these moms. So now I'll give like a proper kind of introduction or details of kind of who I am, what we do, and kind of what I want to talk about today. So as Jane said, I am kind of director of our PD clinic. And as Jane said earlier, and I'm super excited to kind of throw some congratulations to the team, is that we were selected as American Academy of Pediatrics Promising Practice and received an AAP Model Practice Excellence Award. So only 3 in the nation that had received this thus far. And so big kudos to the team. So just to kind of throw some congratulations to the team here. This is our small team of PD clinic and plans of safe care. So left to right, you got Melissa, Becca, Nikisha, and fearless leader, Catherine. Without them, we definitely wouldn't be where we're at today. Like I said, the PD clinic itself was developed from the idea of plans of safe care. And we really wanted to, it initially started with the idea of infants that were born or families that were touched by substance use, opioid use disorder, and quickly grew to the idea of domestic violence, DCF involvement, significant caregiver mental health concerns. And as we developed the PD clinic, we realized just how much wraparound service was necessary for true best practice, right? If you really want to provide the best service and the best practice to these parents, to these caregivers, and to these families, it takes a lot of work to provide that. We also know the importance now, which was noted before, but once you really dig into it, you know the true importance of relationship and transparent care, and those two things being pivotal to mom and baby success. And then the last piece there, just like knowing that empathy and knowledge are key to what we call appropriate care. What's actual appropriate care for these families. And that's what I kind of want to dig into a little bit today. Just touch on a few points that talk about either empathy or knowledge, to kind of get your creative juices flowing. So I want to kind of touch on some observations on psychology, observations on human development, and some empathy and emotion, and try to kind of do some of those thought activities where we reach back into an experience or have some kind of encounter that has us have little kind of tastes of emotion, anxiety, fear, whatever the feeling may be. All right, so let's jump into anticipatory guidance. Anticipatory guidance is one thing that we kind of tout as like a huge pillar to our care for these families, and the idea of uncertainty. So the concept of certainty in human, this is kind of like an observation on psychology and an observation on human behavior. Certainty provides comfort and safety to human. No matter who the human is, certainty provides that comfort and safety. Okay, when we increase uncertainty and the level of mystery, then your stress level goes crazy. You make irrational decisions, and it's kind of overwhelming, and you do things that aren't necessarily in your normal behavior. So I say kind of like think back to the beginning of the pandemic, right? Because I want to take this in a lens of the pandemic. Think about in the beginning of pandemic, right? In the very beginning, as you started to hear information, you started to listen to newscasts like that, you listened to literally 1 million different people tell you 5 million different things, right? And your mind clung on to those things. So what did you do? What was the result of the beginning of those thoughts? Well, what did we do? The beginning of the pandemic, the beginning of quarantine, the first thing, let's talk about toilet paper, right? The great toilet paper shortage of 2020. It's crazy. And the even crazier thing is the fact that history repeated itself. So I'm not sure if it's known, but in 1973, this is also a thing that happened as the toilet paper shortage of 1973 as well, where it started as just almost a humor piece in a late night monologue. And then it kind of got passed on, and someone would say like, oh, I heard on late night TV that there's a toilet paper shortage. That got passed on to, I heard on TV there's a toilet paper shortage. People start saying there's a toilet paper shortage. And that's exactly kind of what happened here in 2020, where the idea that even just the concept, your mind makes these crazy stories where you actually thought that we as a nation were going to run out of toilet paper. You were you were collecting CVS receipts, so something to use in the future if you ran out of toilet paper. Something. It was crazy how we reacted, and we wiped the shelves of toilet paper where there was never a concern for actual supply of toilet paper. It was only a delay in the actual shipment and the actual supply to shops and grocery centers and stuff like that. So there was never, if you talk to toilet paper countries, there was never a problem with actual production. But that's what our mind visualized, because it was such a level of uncertainty. As soon as you heard it, you had to go for it. The second thing was food shortage. And I kind of find this humorous now. If you think back to the beginning of it, maybe your last trip to the grocery store before the shutdown occurred, thinking about the items that you purchased. I know that one of my best friends got like a 12-pound bag of potatoes. And I'm like, I don't think she knows 2 recipes that involve potatoes. So it's like, it didn't matter. It was a certainty of knowing that I had an item, right? My mom actually bought a carton of quail eggs because there were no more eggs on the shelf. So she bought quail eggs just because the fact of certainty of having items, the more number of items she had, she felt more at comfort and more safe. She didn't know that it takes like 34 quail eggs to make an omelet, but it didn't matter. It was an item that she had that provided her comfort and safety. And so the idea is why do these things happen? What kind of, like, why does our mind do this? And in reality, it's because of our primitive survival brain, okay? And it assumes the worst always. It'll always overestimate the threats, because if your brain doesn't know what's around the corner, it cannot keep you out of harm's way. And so what happens is your brain will do almost anything for the sake of certainty, okay? And so when that certainty is questioned, like it did in the beginning of the pandemic, your stress response goes out of control. One of my favorite studies that I cite when talking about certainty versus uncertainty and the idea of safety is a study that came out of the UK like 8 to 10 years ago. And it discovered that participants who knew for sure that they would receive a painful electric shock felt calmer, performed better, and were less agitated than those who were told that they had a 50% chance of getting the electric shock. People chose painful electric shock because of its certainty over a reduced percentage or reduction in risk of actually getting shocked. That's how much our mind is starving for certainty. So they would actually pick pain or a greater chance of pain than uncertainty. So the idea is how do we, in uncertainty, times of uncertainty, times of the pandemic, times of a mother going through pregnancy, times of a mother struggling through a substance abuse journey, how do you go about it? Because you know that it is just riddled with uncertainty. And so the idea is that if you can't have certainty, you can at least at the minimum address expectation. So how do we do this in the PD clinic when I'm dealing with moms that are going through like an opioid use journey during pregnancy? I kind of do it by debunking the myths, offering guidance of what to expect, and what I kind of call redirecting the focus on things that you can control or things that you can expect in expectation. Some of the topics that always come up, because again, as stories and myths kind of spread, they spread like wildfire, because your mind, even if it's bad news, want it because it's certainty. It sounds like there's some kind of certainty. It sounds like there's safety in knowing. So talking about medication treatment during pregnancy for OUH, talking about breastfeeding after I have a baby, talking about the prediction of withdrawal in infants. One of the things, this is the best example of redirecting focus. So the idea that if you have a mom who's struggling with withdrawal symptoms during pregnancy, and she's on a specific dose of, let's say, methadone or Subutex, and her provider talks about, let's increase the dose for the safety of the pregnancy, because your risk of withdrawal during pregnancy is preterm labor or IUFD, intrauterine fetal demise, where the baby dies before it's born. Those are huge risks. And so the idea that the risk of, and I'll get to it in a second, potential of withdrawal in a baby is way less than the risk of fetal demise or preterm labor. Because in reality, our prediction of withdrawal in infants is terrible. Okay, it is known fact through the literature that there's no dose-dependent relationship between what kind of meds or how high a dose mom is on and which babies will withdraw. So I have some moms that I follow closely that are on the highest amounts of medication I've ever heard in my life, and they'll have babies that have minimal to no symptoms of withdrawal at all. Versus I could have a baby or a mom who has never had opioids, never touched opioids her entire life, and then in the third trimester gets 2 courses of pain meds through the emergency department, and she has a baby who has significant withdrawal symptoms. So, and I know that almost provides extra uncertainty, but the idea behind that is when I have a mom who's struggling because she doesn't want to increase a dose during pregnancy, it's giving her the guidance that, listen, the certainty is in the safety of pregnancy, okay? What we can guarantee is that you will not have a bad outcome due to withdrawal if you adequately manage your opioid use disorder during pregnancy, okay? We can't touch what's gonna happen when the baby's born. I 100% will do everything I can in my power to provide the best care, reduction in medication, the best kind of non-pharmacologic care I can for that baby. But in reality right now, in this time right now, when you're pregnant, the goal is a safe pregnancy. And having them redirect the focus and understanding that whatever you do right now during pregnancy will not affect the baby's outcome is huge, and allowing us to partner with them to understand what's really important when it comes to safety. I always tell people, I will 1,000,000 times take a term kid that has withdrawal symptoms over a 24-weeker that was born because mom went into withdrawal. The outcomes are tremendously different, and I would take that 1,000,000 times. So that's the idea of uncertainty, and that's how we try to address uncertainty. And obviously with the pandemic, that has just completely blown up because everybody has increased uncertainty in their life at this time. And that has not helped a lot of my moms that are going through any kind of journey, whether it's domestic violence, mental health concerns, or substance use. Let's jump over to disruption. So I talk about disruption of routine in this pandemic, right? So it's known that you're at your best when you're in the groove or in your perfect routine, right? We do things in a certain way, whether it's at work, whether it's our morning routine, because we know we're efficient, we know that we're effective, and we know that we don't forget things. And so that same kind of idea goes into managing any kind of problem in medicine, and thinking about these moms that are going through a substance use journey during pregnancy, their routine and what's necessary to optimize their outcome includes a strong support system, daily affirmation or daily dosing, some kind of renewal of what I'm doing is for the better of me and for the better of my baby. It includes therapy or counseling. It includes management of life stressors. And all of that is necessary to give what I call just a chance at managing substance abuse. I'm very particular in how I word this, in the sense that I don't say like beating substance abuse. I don't say like getting past substance abuse. I don't say anything, because in reality, I think that it kind of minimizes the idea of substance abuse. If I say it's a thing of the past, we can package it up and throw it behind and never deal with it again. No, we know that it's a constant management. It's a constant journey. And even for those that we would perceive to be beyond it, still deal with it on a day-to-day basis, which for me demonstrates even further strength. So this idea of destruction of what life once was, again, we'll take a look at a perspective of our life, right? So thinking back to a year ago, where were you at in what your life was, and how does that compare to today? Number one, I thought I was good at my job back then. I thought I was a good public speaker. And now I can tell I'm a subpar Zoom speaker. But that's just because that's the world we're in now, right? That was a destruction of what I thought I was good at before. Doesn't help me right now. Financial concerns, and I put that in quotations because everybody has financial concerns, right? Nobody just kind of willy-nilly doesn't worry about money at all. And so what were your financial concerns a year ago, and what are they today? For a lot of people in the community, it's the difference between having a job and not having a job, which is a huge, huge stressor and a complete destruction of what you kind of considered what life was. Days of the week, the concept of felt time. There were definitely times in the middle of the pandemic, in the middle of the quarantine, where you woke up and you said, is today Monday, Friday, Sunday, Thursday? You had no idea, right? And so that really affects your ability to be productive, be efficient at what you do, and affects your ability to kind of live the life that you're meant to live. I talk about social relief, the idea that, after a long day of work, you just want to spend time with your friends, or you want to go visit this person. We no longer have that. And then the other idea of helping others. I kind of talk about an experience in the beginning of the quarantine, where I was living in this cloud of uncertainty and mystery. And there was a time where I saw a lady drop something out of her bag. And instead of what I would have usually done before and walked up, grabbed it, picked it up and given it to her, my mind was a blur because I had no idea. I was like literally like an air traffic controller, like, ma'am, come back, trying to direct her to pick up her own thing because I didn't want to have contact with like a physical thing during the quarantine. Where in retrospect, it was like, I totally could have just given her the object, but it changes what we kind of consider of like what we are ourselves in that destruction of life. We know that everyone's world was kind of turned upside down with that. And I always say, what was the risk in your life to your world being turned upside down? And that's where you get the objective difference. Everybody move on to the next big step of development, and that's auto-regulation or self-soothing. So now that we understand, now that they have a strong sense of being able to know that someone will be there if they're actually in trouble, they can now focus on self-soothing and auto-regulation. Once they kind of have themselves down, now they can start focusing on the outer world, talking about social and inanimate engagement, being able to learn social cues, social growth, being able to learn about reciprocation of faces, sounds, stuff like that. But the idea is that if I have some kind of trauma or bad outcome in childhood, it prevents me. It's a barrier to getting to the next level. So if I have a kid that is super affected by trauma or incorrect parenting and stuff like that, and they cannot get past that auto-regulation ability to self-soothe, they will never be able to optimize their ability to engage with social